evening. Thank you for joining this masterclass to have a discussion about gynecological cancer. So that's cancer affecting the female pelvic organs, so the ovaries, the womb, and the cervix. We're going to be focusing on symptoms of these different types of cancers this evening and what we can do to help prevent them, but also pick them up at the earliest stage that we can, even sometimes before they've started to develop. I'm thrilled to be joined tonight by Dr. Madhavi Vellayan, who's one of our local consultant gynecologists. I'm Dr. Caroline Butler. I'm a GP here at Mythe Medical Practice, and I've got a specialist interest in preventative health and using lifestyle to try and help manage medical conditions. I'll be asking questions tonight as though I was a patient, so speaking to our audience about these different types of cancers. And this will include questions from those that have been asked in advance and those that you'd like to ask during this talk. So please write them into the chat box so that we've got those fed through to us so we can answer them at the end of the session. This talk will be recorded, so if you want to listen to it again, it will be available on the Facebook Live for each practice, but also available on YouTube if you want to listen to it again. We'd love to receive your questions, so do ask those in there as well. So what we're going to do first of all is just show you an image of the female pelvic organs, just so that you get to have a look at what the normal anatomy is. So here we've got the ovaries sitting either side, those white oval areas which are labelled there. We've got the womb in the centre, also known medically as the uterus, and the endometrial lining within that, and then the cervix at the base of the womb, which is we often call the neck of the womb, and they're the three areas that we'll be talking about today. So we're going to talk about first of all is cervical cancer. What is cervical cancer?
So cervix, as we've just seen, is the lower part of the womb, which is the narrower portion. Cervix is covered by cells, and sometimes these cells can multiply rapidly and thicken and undergo abnormal changes. And when these abnormal changes are not picked up or not treated and removed, then it can go on to develop cervical cancer.
And who tends to be affected by cervical cancer?
So it's very rare in young women under the age of 25, and cervical cancer is extremely rare. It tends to be, the pickup of cervical cancer tends to be around 30s. Women between the age of 30 and 34 is where we pick up most of the cervical cancers. But it's not just that age group. There's another peak at later on in 50s, early 50s, when again we have a greater chance of picking up cervical cancer. It's to do with sexual activity. The more sexually active someone is, the greater the chance of picking up cervical cancer at that time. And that's why in the 30s and in the 50s, because of change in sexual partners.
Okay, and are there any risk factors for cervical cancer you can mention?
So 97% of cervical cancers are caused by the human papillomavirus, which everyone will know as the HPV. That infection is what causes changes in the cervix, in the cells in the cervix. It makes it abnormal, and then when these abnormal cells are not picked up and treated, then it can lead on to cancer. So that's the reason for picking up.
And what can women do to try and reduce their risk of developing cervical cancer?
So HPV vaccination is the key for preventing cervical cancer. It's the one vaccination that we now know can practically prevent 90% of cervical cancers from even developing. It's at the moment it is administered to boys and girls from year 8 in school, which is really great news because it was only girls in 2008, but now from 2019 boys are also being vaccinated. It's a single dose vaccine given at year 8, but if any child misses the vaccination, you can still contact school or the school vaccination team and get the injection, and women can have the injection until the age of 25. We like to try and get it before they become sexually active, but even if they're sexually active, it is still worth giving it because they may not be exposed to all the viruses that can cause cervical cancer.
So what other things can a woman do to try and help prevent the development of cervical cancer?
Yeah, so HPV vaccination, and then followed by active participation in the smear program. If a woman regularly attends a smear recall, has the smear done, and if there's any follow-up smears that are needed because abnormalities have been picked up, if they have it in a timely fashion, then the chance of picking up cervical cancer is very, very low. So that would be key, is to always regularly attend the smears and not to miss it. Smoking is another thing that women can do in terms of stopping smoking, because the HPV infection, women are capable of clearing it. Our body immune system will fight it and try to get rid of it, but we know that smokers tend to not clear the infection that easily. So stopping smoking will help.
Okay, so stopping smoking, attending your smears, and receiving the HPV vaccine. And obviously the smear program starts at the age of 25, goes through to 64 with intervals of 3 years initially, and then after 50 goes up to 5 yearly. But why does it only start at 25?
HPV, the virus infection, is very, very common. The more sexually active you are, the greater the chance of having the virus. So if women under the age of 25 have smear tests, we're highly likely to pick up the virus. You may then say, so why don't we then pick it up and treat it early? But just like how we can pick it up easily, we can also clear it easily. Within 2 years, most women will clear it. 90% tend to clear the virus. So if we do smears before the age of 25, we will cause a lot of anxiety and concern, and we will also end up interfering and doing some treatments which can then have long-term effect on their fertility and future pregnancy, etc. So we tend not to do it before the age of 25, because at that time cervical cancer is not likely to have developed, but more that the HPV infection might be present. But by the time we start doing the smears at 25, if the virus is still present, then we can act on it, because those are the group of women who have not managed to clear it by themselves.
Yeah, okay. And it stops at the age of 64, presumably, as you said, the peak age has passed.
And if a woman who's had no abnormal smears and reaches the age of 64 and the last smear is also normal, then the chance of cervical cancer is very, very low.
Good. Okay, so the smear program has changed quite a lot in the last 20 years since I've been a doctor. We used to use wooden implements, we used to use metal speculums, which are quite cold, and now we're using brushes, which are quite flexible and more comfortable, with plastic speculums. That often helps women to attend for their smears because they know it's going to be more comfortable. We also, in general practice, if we've got a postmenopausal woman who finds that they've got some vaginal dryness or discomfort, we would often introduce vaginal estrogens to try and make that tissue more comfortable, so that we can introduce a speculum more easily, that little plastic device that widens the vagina so that we can take the smear. Is there anything else that can be done to help those women who are frightened about coming to have a smear done or have avoided it in the past?
Lubrication, which you use, will help. But we're all different, and the cervix can be in different positions. And the longer it takes to identify the cervix, the more uncomfortable it is for women. Because some cervix can be in the front, some at the back, some on the right, left. So often when smear is being done, and if the nurse or the nurse practitioner or the doctor finds it difficult to identify the cervix, it's often useful to find out where the cervix is, as well as what sort of speculum was used. I mean, I love it when patients come to me and say, long speculum, please, because then you're not going through a range of speculums. So that's something that you can do to help yourself, but also sometimes positioning the patient to the edge of the couch means that the pelvis opens up, and it's a lot easier than to quickly identify the cervix and take smear. But there are some women who would still find it very uncomfortable. If that's the case, then we're quite happy for you to refer patients to the hospital. And we often have gas and air in the hospital, and we can use this so that women are a lot more comfortable and can tolerate the speculum when it's inserted.
Yeah. But I think having it done with an experienced person can often help as well, as you say, to reassure them.
It's the short time The quicker it is,
yeah,
the more comfortable it is.
yeah. And for some of my patients, they have got learning difficulties who couldn't go through a speculum examination, then I often refer them through to yourselves.
Yeah.
In order for that to be done.
Yeah, so in the hospital to begin with, we can give them more time, allocate more time, but also have more staff. But you know, if the patient is very anxious and can't tolerate it, then they don't have to go through it whilst awake. We do discuss and offer general anesthetic as an option.
Okay, so if women have not attended the cervical smears or unfortunately developed cervical cancer, what sort of symptoms might they develop?
So the symptoms of cervical cancer will often overlap with lots of other symptoms, but it would be typically bleeding at times when you don't expect it, which could be after sexual intercourse or it could be between periods. But again, bleeding between periods is often due to a lot of other reasons, such as hormone disturbances, and sometimes because of the hormone you're on in the form of contraceptives. But usually bleeding that is very persistent and constant all the time, or every time you have sexual intercourse, but even between sexual intercourse, when there's just a little bit every day, not big bleeds, just a little bit every day, that's more worrying. And that's when I'd be more concerned. I'd be more concerned about a patient who says that they have some blood or the other all the time. When they wipe themselves, they see some blood.
Yeah. So we would ask those women to come to us as GPs to have a look at the cervix. And if we're looking at the cervix and there's something that we feel that it doesn't look right, we would be referring on to yourselves to try and assess it further. What would those women expect to undertake in the clinic?
So we'll usually give them an appointment within 2 weeks to be seen in the cancer exclusion clinic. And the thing I want to say here in Gloucestershire is that they've audited our cancer exclusion clinic, and 95% patients who are referred to the cancer exclusion clinic do not have cancer. So we examine the patient, we take the smear history, find out if they're up to date, and then we put a speculum in and look at the cervix. What we're looking to see is whether the cervix appears normal. If it looks normal, we'll be able to reassure you, because a lot of times hormone changes can look abnormal, but because we're experienced, we can look at it and we can reassure patients. But if we see any abnormality, then with patients' consent, we can take a small sample, like a biopsy from the cervix at the same visit, and then we send it off to the lab and take it from there. Excellent.
Okay. So really important message with that section is about prevention and about attending the cervical smears. And it's worth saying at this point that each of the surgeries within the Twins Network has set up some catch-up cervical smear appointments, so that in coming weeks and months there'll be the opportunity to book into those. But don't hold back from speaking to your surgery in order to book that in if you know that you're due.
There's just one thing I wanted to say. The cervical smear is not designed to pick up cervical cancer. It's designed to pick up the precancerous changes in the cells and pick up the HPV. So that's what a lot of patients think, that it is designed to diagnose cervical cancer. It's not for that. It's to find out that they've got the HPV virus, and if it's a high risk HPV, then they look at the cells to see if there are any abnormal changes. And we are only looking at precancerous changes, because then you get in there and treat the precancerous changes and you prevent cancer.
Yes, yeah, absolutely. So that's what the smear program is trying to pick up, is those precancerous cells before you've even developed cancer. Yeah, absolutely. Excellent. Should we move on to ovarian cancer? So if you can tell me first of all, what is ovarian cancer? Why does it happen?
So again, in the picture, the ovaries are 2 organs. We all have 2 ovaries each, 1 on each side, and these are the ones that produce the eggs and also produce the hormones, the estrogen, progesterone hormones. When the cells in the ovary sometimes multiply rapidly and get thickened and form a cyst or a growth, and has abnormal cells, that's when ovarian cancer happens.
That's when it happens. And who does it tend to happen to? Which types of women?
It can happen at any age, but majority of ovarian cancers are in older women. It's very rare. It's rare under the age of 45, but in older women, especially women in their 70s, is when we tend to pick up more ovarian cancers. About 20% of ovarian cancers are linked to genes. You might have inherited a gene that makes you more prone to develop ovarian cancer, and such women are more likely to have more than one member in the family who've had an ovarian cancer.
Okay, so with ovarian cancer, for us as general practitioners, it's a real challenge because there isn't an appropriate screening program, is there, for ovarian cancer? But also because the symptoms are often quite slow to develop or quite difficult to pick up. Can you talk to us a bit more about that?
Yeah, so unlike cervical cancer, where if a cervical cancer is diagnosed, 75% of cervical cancers that are being diagnosed are all very, very early stage, so highly curable.
Yes.
Whereas the ovarian cancers, when we diagnose them, about similar numbers, 75% are already in an advanced stage. And the reason for this is because they don't really present with any symptoms early on. And by the time women present with symptoms, it's quite advanced in stage. And the symptoms are also, broadly speaking, quite big.
Yeah.
But the symptoms that we'd ask women to watch out for is bloated sensation in tummy. And again, that's quite a common symptom for women. But we're talking about persistent bloated sensation that persists and doesn't go away for over 2 weeks, rather than one that comes and goes, or when you have an upset tummy. Also, tummy discomfort and pain associated with that distension. Feeling full very quickly, unable to eat, and losing weight quickly, and a pressure sensation in tummy. All of these symptoms, especially in older women, if it's present and it's not going away and it's persistent, then must see GP.
Yeah, absolutely. So those, because of the challenge and the fact that it presents quite late, it's something that we as GPs often think about quite early with those symptoms, especially if there's been a new or a change of those symptoms that we would be looking at. And sort of 2 weeks or more of those symptoms would be indicating that we need to do further. So what we would do is bring them into the clinic and examine them after taking a history, and then feeling if there's any swelling that we can feel in the lower tummy, and would then go on to usually arrange blood tests and a scan. Blood tests would be looking for a CA125. What is the CA125 and what's that looking for?
So CA125 is what we call as a tumor marker, which helps to pick up if there's a tumor in the body. It is a chemical that the body produces and it's naturally present, but in ovarian cancer, it will be really raised.
Okay.
So when the value is raised and woman presents with the symptom, then that's a bit more alarming, and then you want to do an ultrasound scan to check the ovaries and see if there's any growth or cyst.
Okay, and the CA125, is it always raised in ovarian cancer?
Yeah, so it's not always raised. But in some very early cancers, it can be. Very early cancers or certain types of cancers, it may not even be raised.
Yeah.
But it tends to be when it's raised, it's usually cancer that's already in an advanced stage.
Yeah. And it can be raised in other conditions as well, can't it?
Correct.
Like ovarian cysts or other benign, non-cancerous.
Yeah, even a period, an upset tummy,
Yeah.
any infection inside, that can also raise the CA125, because it is a chemical produced by the body as a reaction to something happening. So it can be raised in other conditions. So that can confuse the picture as well.
Yeah.
But in ovarian cancer, it tends to be raised a fair deal.
So if we've got a raised CA125 and or an abnormal ultrasound scan, we would be referring through to yourselves again to the cancer exclusion clinic.
Correct. Yeah.
And what would be likely to happen in that clinic?
So you get seen within 2 weeks, and we take a history, we examine patient and see if we can feel the swelling. We then review the scan pictures as well as the report, and we'll be able to then tell the patient with a reasonable certainty whether we're not worried about the cyst, because there are lots of different ovarian cysts like dermoids and endometriosis related cysts where the CA125 can be slightly raised. We can reassure the patients and say that this is not cancer, it's a non-cancerous cyst, and then discuss what needs to be done. But if we are concerned about it, then we want to organize further tests like MRI to get more information, and then as part of a multidisciplinary team discussion, we then come up with a management plan.
So the symptoms are the key thing for ovarian cancer. and screening program we didn't specifically talk about, but why can the CA-125 not be used for screening?
Like I've said before, it's not very specific for ovarian cancer. It can be raised for a lot of other conditions, and therefore, if we start using that as a screening tool, like we do cervical smears, we'll be causing a lot of anxiety, we'll be investigating unnecessarily, and women will be undergoing surgery unnecessarily and having their ovaries removed when there was no need to. And it's also been tested and it's not reliable. Unfortunately, we are yet to find a reliable screening test for the ovarian cancer.
Yeah, and it also can happen, ovarian cancer can happen without the CA-125 being risen as well.
Yeah.
And talk about prevention, we talked about that with cervical cancer. Is there anything that a woman can do to prevent ovarian cancer?
Unfortunately not. Like I said, like 80%, there's no particular reason. It does tend to be slightly more common in overweight women. There's a link with, again, a slightly increased risk with diabetes, but very small increase. Women with polycystic ovaries, they can also, sorry, I didn't mean polycystic ovaries. Women with endometriosis and endometriosis-related cysts, they are slightly at increased risk.
Okay, but ever so slightly. Okay. So, as you said, really important to look out for those symptoms and come to the GP if they're developing more than 2 weeks of particularly bloating, pressure sensation, and discomfort in the lower pelvis, which has developed persistently over 2 weeks, or change in bowel habit. Those sorts of symptoms I want to come in for. So should we move on to endometrial cancer?
Yeah.
So what is endometrial cancer?
So endometrial cancer, endometrium is the lining of the womb. The lining of the womb undergoes a dynamic change throughout the cycle for women. It thickens the period, it thickens throughout the cycle and then it sheds. So it's always undergoing changes. But in postmenopausal women, especially who are at risk of endometrial cancer, the lining of the womb can thicken and undergo abnormal changes, and then undergo cancerous changes, and then endometrial cancer.
Okay. Okay. And who tends to get endometrial cancer?
It's again a condition that's quite rare under the age of 45. Women are at increased risk over the age of 45, but typically it's a condition that's a lot more common in postmenopausal women. So when we say postmenopausal, we're talking about women around the age of 50 who has stopped periods for a full 1 year. Then they are postmenopausal from then on. Not because their periods have stopped because they have a Mirena coil or they're on the mini pill, but women who are truly menopausal. So these postmenopausal women, they are the ones who are at highest risk of developing womb cancer. Apart from age, there are some conditions that again make you more prone or at high risk for developing womb cancer, and that would be women who are overweight. Women who are overweight are significantly at risk of developing womb cancer. Women who have not had children, women who have diabetes, raised blood pressure, and also women with polycystic ovaries. They're also at increased risk of developing womb cancer. In all these risk factors that I mentioned, the estrogen levels tend to be higher, and that is the main risk.
Okay, that's the main risk, and so therefore accommodating for those lifestyle changes may be helpful to try and reduce their risk. And for a woman who develops endometrial cancer, what kind of symptoms might they develop?
So compared to ovarian cancer, where there's hardly any symptoms, and by the time they get symptoms, it's too late. With womb cancer, the good thing is majority, and we're talking like really nearly 100%, will present with bleeding. So abnormal bleeding happening in a postmenopausal woman always needs investigation. So that's how they're present. Perimenopausal women, they can get it too, but it's not as common as postmenopausal. In those women, it would present as bleeding problem, but not just as a heavy period, but more as a bleeding that is constant and continuous and doesn't respond to hormones or Mirena coil or any treatment that GP would normally give. Okay. So that bleeding, abnormal bleeding in the postmenopausal women, so as you said, a year after your last period, if having any abnormal bleeding in that time, you've got to come to us. There are other reasons, aren't there, that bleeding can happen in that time, for example, being on HRT. Yes. So hormone replacement therapy perimenopausal women are on it, but also postmenopausal women are also on HRT. And HRT, unfortunately, irregular bleeding on HRT is very common. About 40% of women, regardless of which kind of HRT they are on, whether it's the bleed one or the bleed free one, tend to have some bleeding or the other. And so it causes a lot of anxiety because women don't expect to have bleeding, but it is very common. The good news about it is that women who are on the continuous combined HRT, which is the bleed-free HRT, they actually have a lower risk of developing endometrial or womb cancer compared to women who are not on HRT. And the HRT, which gives a monthly bleed, it does not increase the risk. But this is all assuming that the HRT is taken in the right way, with not a very high dose of estrogen, taking the recommended dose of estrogen and getting adequate progesterone treatment along with it.
Yeah, okay. So the first thing that we do if a woman is on HRT and is presented with abnormal bleeding after examining them would be to, we're recommended to stop that HRT for a period of 6 weeks. Can you talk to me a little bit more about that?
Yeah, so the reason for asking women to stop is most often the bleeding is because of hormones, and troubleshooting the HRT will help. But sometimes just taking a break from the hormone will let the body reset, and then it can be reintroduced. That is the main reason for asking to give, and we commonly refer to it as a washout, just to get rid of the hormones and then reintroduce it. Because I know a lot of women will struggle when you stop HRT, but a little break will help, and often there can be other medication that can be given in the interim for hot flushes and night sweats. But there's also another reason, because it is very common, bleeding with HRT, it's hard to distinguish whose bleeding is abnormal and whose is not. And if we can't differentiate it, and if we refer all these women, then we'll then find that the women with womb cancer will have to wait longer because there'll be too many patients to see and there'll be too many interventions. So that's the reason we asked to stop, because any bleed that's HRT related bleeding, hormone induced bleeding, will settle within 6 weeks, and there won't be any bleeding beyond 6 weeks. But if somebody has stopped their HRT and their bleeding is still persisting beyond 6 weeks, those are the ones we'll be really worried about, and that's why those women should then be referred to us, and we'll see them on the 2-week wait pathway.
Yeah. So anyone who's not on HRT, postmenopausal, who's bleeding would be sent through to that pathway, or someone whose bleeding hasn't settled after 6 weeks off HRT. If there's a woman who feels that they are extremely symptomatic of their HRT and they really don't want to stop it, what can we do for them?
As I said, HRT troubleshooting will help, but if there are concerns and GP is concerned about the bleeding and whether there's a risk of womb cancer, we'll still be very happy to see them, and you refer the patients to us via the urgent pathway, and we tend to see them within 6 to 8 weeks.
Okay, so they can opt to go down that pathway if they really want to. And then what would those women expect at their clinic appointment with you in the cancer exclusion service for endometrial cancer?
Okay, so when you refer a patient to via the 2-week wait pathway for endometrial cancer or womb cancer, then we arrange an ultrasound scan. And then once the ultrasound scan is usually done within a week, and then the scan results will be reviewed. And based on the scan results, then we decide whether the patient should go and see a gynecologist. And what we're looking at the scan is we're looking at the lining of the womb to see how thick it is. If the lining of the womb is thin, that's already very reassuring. Or if it's only just marginally thick, then they tend to go and see a gynecologist in a cancer exclusion clinic, where they will be examined and a biopsy might be taken from the lining of the womb. But if it's very thin, then we just look at the cervix, because often the scan is not very good in picking up cervix. It can't comment that much on the cervix, so we like to look at it to make sure it looks okay. But if the lining is slightly thicker, we take a biopsy. But there are some other women, based on scan, where we would decide that it's best that they go to a hysteroscopy clinic. A hysteroscopy is a telescopic examination of the womb, and so that we can insert the telescope and have a look and see if there's any abnormality, polyps, and perhaps remove it at the same time.
Okay. And we haven't talked about screening for endometrial cancer. Can you talk to me about that?
Okay, so the only way to screen for endometrial cancer, similar to cervical cancer, where we can just take a brush from the cervix, with endometrial cancer would be to actually take a sample of the lining of the womb.
Yeah.
It is an uncomfortable one, and we at the moment have no evidence to say that that's going to be beneficial and who to do it and how often to do it.
Yeah.
And we haven't got the data for that, and we will probably end up causing more harm than benefit by doing that. And another point about womb cancer is it does tend to present with bleeding problems. So therefore, we should target trying to find out if there's womb cancer or not in women who present with those symptoms.
Yeah. And the other thing I think about endometrial cancer is in a woman who's like high risk patient, for example, as you mentioned, somebody who is overweight, may have diabetes or hypertension, or they may have heavy bleeding anyway, but they might then be looking at options for contraceptive or HRT. We often talk about the Mirena being quite a good choice for them because that reduces their risk of endometrial
100%. So the thicker the lining of the womb, the greater the chance of it undergoing abnormalities. And what the Mirena coil does is it actually thins down the lining of the womb. So it's a good thing to have, especially if you've got all the risk factors and have bleeding problems, because it will thin down the lining and prevent it from multiplying.
Okay.
It won't prevent it 100%, but it will greatly reduce the risk.
Okay, excellent. Okay, so endometrial cancer, bleeding which is persistently abnormal for that woman, particularly a postmenopausal woman or maybe perimenopausal, and then they need examination and assessment, possibly stopping the HRT if they are on it, not definitely stopping it if they are on it, but if they're not, then they'll be referred through to the clinic or if that persisted.
Yeah.
Okay. So we've covered those three types.
The other thing about womb cancer is that, and I probably mentioned it already, but 75% of the endometrial cancers that we diagnose are all early stage. So it's very curable by operation, and there's only a small proportion that would have spread and might need more treatment.
So very different to ovarian cancer, is the other thing anyway.
Yeah.
Excellent. Okay, so we've got a few questions that have been asked on screen, so we're going to move to those next. So we've got Sarah asking why a smear's changed to 5 years when you hit 50.
So the reason for that is that if you've had 3 early smears and you've not had any abnormalities at all, then the chance of picking up HPV, high risk virus, drops at that age, and that's why it's moved on to 5 years. But even if a woman, so long as they attend every 5 years, will still be able to pick up any changes. And we're only looking at precancerous, not cancer. We can identify these precancerous changes because of the HPV and treat them.
Okay, and we were asked a question prior to the talk about whether we can extend that screening similar to breast cancer screening or bowel cancer screening, but in cervical cancer there isn't that option because it's less likely.
Yeah, on the NHS it's not available on the NHS because the screening program ends at 65. Because if a woman's had regular smears up to the age of 65 and no abnormal smears in the last few smears, then the chance of developing cervical cancer is extremely rare. Yeah, so there would be no need to do it.
Some women do come to us and ask for an annual cervical smear or to have it done privately, which are options to them, but there's no benefit seen from those actions.
No. But there are some women who are more at risk, but they will be individualized, like for example HIV patients, more they get more smears done because they don't have the immunity to clear HPV if they pick it up.
Yeah. Okay, all right. And Harriet asks, if my mother and grandmother had ovarian cancer, what testing is available for me and my sisters?
Okay, so if there's one person affected with ovarian cancer, you are already like 3 times at risk of developing ovarian cancer. And if there are 2 family members, then you are significantly greater risk of developing ovarian cancer. So you then need to be referred to genetic testing to see if you're carrying the gene which might be responsible for making you more prone for ovarian cancer. So
So approach your GP,
Yeah.
to discuss and then be referred on
Yeah.
from there. Yeah. And there's also sometimes an overlap between different types of cancers, aren't there, as well?
Yeah, so breast cancer and ovarian cancer tend to go together. Womb cancer and bowel cancer tend to go together when there's a genetic link.
Okay, interesting. Claire asks, if you've had a total hysterectomy with the conservation of the ovaries, would you still be at risk of ovarian cancer?
Conservation of ovaries, yes. As long as the ovaries are present, then you're at risk. Hysterectomy does not protect you from getting ovarian cancer, because a hysterectomy means removal of the womb. If the hysterectomy is done and the ovaries are removed, then you cannot get ovarian cancer. But if the ovaries are left behind, you're no different to anyone else.
Yeah. And I think on that note, talking about hysterectomy, if you've not had a total hysterectomy, so the cervix is still present, it's really important that you still get your smears and you still attend for your smears. But for those women whose cervix has been removed, then they no longer need them. Obviously, they don't need to attend for smears.
Yeah, correct. But even at the hysterectomy, the sample is analyzed and they'll make sure that the cervix is completely normal, because if there's any abnormality picked up, then you would need more smears taken from the top of the vagina.
Okay.
So the hysterectomy where the cervix is conserved is called subtotal hysterectomy. And if you've had a subtotal hysterectomy, the surgeon will usually make it very clear that you have had a subtotal hysterectomy, which means you still have cervix and continue to participate.
Yes. Okay. So Tony's asked a question about having smears in older women, and I hope we've answered that for his wife. Denise asks, can white patches or pain near the vulva be a sign of cancer?
If you have a white patch in the vulva, you do need to get it looked at, but majority of the white patches are not, because there's a variety of vulval skin conditions that can cause white patches. Lichen sclerosis is one of them, but you can get leukoplakia. But if you have a new patch that develops, and especially if it's painful, burning, itching, then it's best to get it checked.
Absolutely.
Because lichen sclerosis, for example, which is very common, and you can look at it and you can come up with a diagnosis.
Yes.
So it's best to see your GP.
Yeah, absolutely. And if we have any concerns, we do refer on to the gynecology dermatology specialists. Sarah asks, can non-cancerous cyst develop into a cancerous cyst?
Very unlikely. Very unlikely. Most of the time, a non-cancerous cyst that's being operated on is being operated on for pain, or because of how big it is and how it's pressing. And also some cysts, like dermoid cysts, we just know will never go away and will keep on growing. And they can also, they tend to twist because of how heavy they are.
Yes.
So we operate on them, but it's very, very unlikely. If we operate on a non-cancerous cyst, we're operating because of symptoms, or because patient would like it operated or is concerned about it, not because we're worried about it becoming cancers.
Yeah, and we can tell that by the ultrasound, can't we? Because they're often thin-walled, fluid-filled.
And we still do that blood test, the CA-125.
Yeah. That was a really useful question. Jenny asks, are you more at risk of womb cancer if you've had heavy periods with clots?
Just having heavy periods, it's really common, and that doesn't put you at risk of developing womb cancer. But if you don't go through menopause around your 50s, and if your menopause is late menopause, or you started periods early, then that puts you more at risk of womb cancer, because there's a lot more exposure to estrogen. So late menopause, I mean, GPs, you'll know, if you have a woman who's 57, 58 and still having periods, they're often concerned about it.
Absolutely. We've got another question. Can you still have sex if you've tested positive for HPV?
100%. Yes.
It's just so common, isn't it?
Yeah.
So we've got a few questions to ask beforehand. So menopausal women on estrogen tablets with a Mirena coil fitted has had no periods for many years, but experienced some pink spotting just for a couple of days. Is that a concern?
So much depends on what the age of the patient is.
Yeah.
Because pre-menopausal women, although Mirena tends to stop periods, it's not a given that there will never ever be any bleeding. You can sometimes, your ovaries can still make you have a bleed, and that's not unusual. So it's not that a little pinky discharge don't need to be too worried about it, but you need to keep an eye on it. If that becomes more frequent and very random, as in it can happen anytime or sometimes continuous, that's more worrying than you notice this pink discharge and then you note it down, and then you notice that 1 month later you've had again a pinky discharge. A month later it lasts for a day. It's a period. Mirena will stop periods for most, but for some it can stop periods and then periods can return. So it's all about keeping an eye on it and not to be not to panic just because you had one episode.
Now, is there an odor that could suggest a problem? I suppose of the blood or perhaps discharge.
Well, if there's an abnormal vaginal discharge in the sense that it's smelly, then the first thing you need to think about is whether you picked up an infection and get it checked. But in very advanced cervical cancer, there will be a malodorous discharge, which will be constant, persistent, will not respond to antibiotics. That's like very rare. We don't really see that many. I mean, I probably would see two a year. That can be very foul smelling. Sometimes, rarely, although I said womb cancer will present as abnormal bleeding, womb cancer can also sometimes in postmenopausal women. So we're looking at older postmenopausal women present as vaginal discharge, excessive discharge. Postmenopausal women, especially older women, do not have excessive vaginal discharge. So there's a lot of vaginal discharge. That might be a reason to see GP, just to get an ultrasound scan, an examination, and see what's going on.
Okay. Next question: when should abdominal bloating and bowel changes become so much of an issue that you go to your GP? Symptoms are common in the menopause and perimenopause. So when should we be worried? So we answered that earlier on, but perhaps you could just confirm that again.
So as the question says, it's really common. It's common in young women. It's common in perimenopausal women. But it's about keeping an eye on that symptoms, and is it just triggered by a particular diet, or is it just always in the evening and then it's all back down to nice and flat in the morning? It's about keeping an eye on the symptoms. If it's persistent and constantly bloated, and beyond 2 weeks, that's when we need to be concerned.
Okay. There's another question from Amy on the group. Says, are you more likely to get endometrial cancer if you have endometriosis?
Not really, but if you have endometriotic cysts and you've got severe endometriosis, they are more at risk of ovarian cancer.
Okay, but not of endometrial cancer.
No.
Should I be concerned if there's pain when I'm having sex or bleeding after? The bleeding after, I think we've explained, but pain.
Cervical cancer or womb cancer or ovarian cancer, they don't present as painful sexual intercourse. So if you have painful sexual intercourse, obviously you need to see your GP to address that issue. But I wouldn't be concerned about cancer.
Okay. You've talked about excessive discharge as something to be worried about, and genetic links to these cancers. So we've talked about the genetic links, particularly for
ovarian cancer. Ovarian cancer can be linked to breast cancer, and womb cancer can be linked to bowel cancer.
Any link with cervical cancer?
No. That's something to know, because a lot of patients come to us and say that they're anxious that they may have cervical cancer because their mothers had cervical cancer. It has absolutely no genetic link, and the only thing that causes it is HPV
and smoking increasing that risk because you can't clear it. If you've had no periods for many years and suddenly start to bleed, would this be an indication? I think we know the answer to that.
Yes, definitely. That's the postmenopausal bleeding that needs investigation.
I'm worried that the new cervical smear test doesn't actually look for cancer cells. Is this right? And goes on to say, can I have a smear test to actually test for the cancer cells, or have it done more regularly than every 3 to 5 years?
Okay, it's actually a very good question, and it's probably something that we didn't really address in detail earlier on, so I'm glad about that question. So we know that over 90% of cancers in the cervix are caused by the HPV virus. So that's what we need to be looking for, and that's when you are likely to pick up changes rather than looking at cells. If you have the HPV, they're only looking for high-risk HPV. High-risk HPV is the virus that will cause cervical cancer. Once you have a high-risk HPV, then they will start looking at the cells. So the cells of your smear will get closely looked at if you have high risk virus. If there are no abnormalities, then you're not likely to have cancer. However, we're aware that you have the high risk HPV, and then the advice will come from the screening program about repeating the smear in a year's time. So that would be the most effective way of the smear program, especially now with the HPV vaccination also started, is to look for the high risk HPV, and then if it's present, then look at those women because they are the ones who are likely to have precancerous changes.
So that's what we do currently. And so if you've got no HPV, we don't need to be worried about that cancer developing.
No. So if they look for HPV and the smear has no HPV, then you will not have an abnormal smear.
Yeah, excellent. Okay. I can see another question here. If you have a family history of ovarian cancer, what age should you consider genetic testing?
Okay, so if you have I would generally say women who have a strong family history of ovarian cancer with several members affected, probably already someone's had testing and you know. But if nobody's had any testing, if you want to have children, I'd say complete family as quickly as possible and then have the testing. I mean, you could have at the age of 30, and if it shows that you are a carrier and are at risk, then you probably, if you want to have children, you need to get on with it and have children, and then consider preventive treatment, which would most often, depending on the risk, be a recommendation to have the ovaries removed. What you don't want is to get testing done for teenagers because that would put a lot of pressure on young women.
To have a family. Yeah. And the same with endometrial as well, if the genetics have been identified that there was an increased risk.
So unlike ovarian cancer, genetic testing is done for womb cancer when bowel cancer has been diagnosed. Usually it tends to be bowel cancer. When young women get bowel cancer and there's a family history, then this condition called Lynch syndrome is suspected, and then that's when genetic testing is done.
Yeah, so the other way around. Okay. I think that completes the questions that we've got. So I wonder in the last few minutes if you could just summarize the key points that you'd like our women to take home for tonight.
So really, healthy lifestyle, eat healthy, keep your weight in check, because being overweight puts you at significant risk of developing womb cancer in your postmenopausal age. But also there's a link with ovarian cancer. So maintaining a healthy weight, stop smoking because smoking lowers your immune system and you're more prone for developing cervical cancer because you can't clear the HPV infection. Vaccination for everyone, for every child from year 8 onwards. That is going to be a game changer for cervical cancer in future. We're already seeing a reduction. It's the only cancer in the female cancer that's actually reduced. On the other hand, womb cancer incidence has gone up in UK, and that's to do with body weight because we are getting heavier now as a country, and therefore womb cancer incidence is increasing. So healthy weight, regular smears, because that's probably the best screening program ever that has saved hundreds of lives and prevented cancer deaths. So attend smear program regularly. If you've had vaccination, you still need to go for cervical smear testing because vaccination will only prevent 90% of the infection. So there'll be some infection that still can't be prevented, and that's why you need to have the smear test so that you can identify whether you still have the HPV infection and whether there are abnormal cells, and then get the abnormal cells treated before it becomes cancer.
Yeah. And then the importance of recognizing symptoms that we want patients to present with. Being the bleeding after intercourse or in between the period, particularly those that's being persistent, for cervical cancer, but also for endometrial cancer, especially in that woman who's around the menopause time. And in ovarian cancer, being those non-specific symptoms that we mentioned earlier on, abdominal pressure, pain, bloating, and
especially in older women.
Yeah. So coming to us at an early stage.
Yeah,
that's great. So speaking to that and the prevention, there's a number of links that we're going to add to the talk at the end about, particularly for Healthy Lifestyles Gloucestershire, which is everyone can access who would like to have help with stopping smoking, with trying to improve their lifestyle. So maybe increasing exercise and help to get support with doing that, although it's not usually the route to significant weight loss, but also talking about healthy benefits that you can gain overall, looking at diet to try and help with weight reduction through Healthy Lifestyles Gloucestershire. You can use, you talk a lot about the Freshwell app, which is a lower carbohydrate approach to weight loss. But ultimately, the Healthy Lifestyle Gloucestershire will be able to help and support you to get to those avenues of treatment. Your own GP surgery may be able to offer you smoking cessation support as well. Attending your smears, as I mentioned, there'll be some dates available for you for specific clinics that are going to be developed for smear taking in case there's a high demand for that in coming weeks and months. But if you know that you're due and you've had a letter through for your smear to be done, do call the surgery and book that in for yourself. And vaccination, if you haven't had, if your child hasn't had it as HPV vaccine, or you're an adult below the age of 24, you said? 25. Then do seek that, usually through the school nurses if they can offer it, or through your GP surgery. So there's still benefit in doing that. Thank you so much for going through that tonight.
Thank you. Thank you for listening.
Thank you.